And now we'll hear Dr. Brendan O'Shea on the GP's perspective.
Good afternoon, Justice Lafoy, ladies and gentlemen of the Assembly. My name is Dr. Brendan O'Shea. I'm from the Irish College of General Practitioners. Thank you very much indeed for requesting the ICGP to have an input in the business of the Assembly today. In delivering our submission and our paper, we have reflected on the activity of the College in this very important area of care during the last many decades. And we've also reflected among ourselves, and we're bringing our observations to you, and particularly taking the brief from the Assembly. We're looking to deliver perspectives from the medical profession on how the current regime operates in practice, and particularly the position on the ground for women who come in and consult in general practice and the experience of general practitioners. With respect to the paper we're presenting, we'd just like to do a very brief background. We'd like to reflect on crisis pregnancy and how we see it in practice on a daily basis, what we've tried to do in terms of prevention of crisis pregnancy, on the management of crisis pregnancy in our communities and our surgeries, and particularly on issues relating to the Eighth Amendment. We have some summaries and conclusions for you, and a brief appendix of current observations in terms of how we see things at the moment. General practitioners are particularly familiar with reproductive healthcare challenges facing Irish women. Irish GPs provide antenatal care to Irish women during pregnancy. Before 20 weeks gestation, GPs provide most antenatal care and support to pregnant women in Ireland. After 20 weeks, GPs provide shared care with hospital colleagues in obstetrics and midwifery. So we're very much engaged in this part of care. When a pregnancy is unwanted, GPs frequently support and care for women through this difficult experience. Evidence-based management of crisis pregnancy provided by GPs is set out in relevant ICGP publications, including guidelines on crisis pregnancy from 2004 and more recent updated guidelines from 2014. Further, Irish GPs provide high-quality contraception to Irish women. Thus, we feel that we are reasonably well placed to understand the concerns, the fears, the experiences of Irish women regarding reproductive health care generally, and especially in relation to the area of early pregnancy, unplanned pregnancy and crisis pregnancy. The implications of the Eighth Amendment and the associated legislative acts are closely considered throughout this paper. Crisis pregnancy. We've already had a definition, and it's a good definition. It's a pregnancy which is neither planned nor desired by the woman concerned and which represents a personal crisis for her. As we see it in our practices in your communities, crisis pregnancy affects women at any age, of any social group, or in any geographical community. Effective management requires attention to a broad range of clinical, social, emotional, educational, and legislative issues. The response of the GP or other healthcare professional at the initial consultation is known to have a very important and sometimes profound impact. The importance of the woman and her partner having a personal doctor available through this time, or indeed many other difficult times, is difficult to quantify, but it's greatly valued. It's very important to us as GPs that we maintain that strand of personal care at this really difficult time. Detail is already presented to the Assembly in relation to the incidence and the outcomes in pregnancy, so we're not going to go over that again here for you. But it is sufficient in the context to observe that irrespective of our legislation and the Eighth Amendment, termination of pregnancy remains a mainstream aspect of medical care for many women resident in Ireland, for their partners, and indeed for general practitioners. Prevention of crisis pregnancy. GPs are well placed to provide effective, accessible contraceptive care to Irish women. GPs, we hope, are still trusted professionals, knowing patients over time with strong doctor-patient relationships. GPs try to promote and be proactive in making available effective and accessible contraception for all women who are sexually active. The greater majority of GPs provide contraception, emergency contraception, crisis pregnancy counselling and post-abortion care, doing so as part of a highly accessible national network of points of readily accessible care. There are GPs and practice nurses in every neighbourhood you care to visit. Despite the efforts of government, educational initiatives and healthcare practitioners, and despite widespread access to emergency contraception, we concur that crisis pregnancy cannot always be prevented, and 35% of all Irish women, as you've heard, who have been pregnant describe having at least one crisis pregnancy. This is really common. It's usual for most GPs as the first point of contact for individuals to encounter women and sometimes their partners in an unplanned, unwanted pregnancy. It is a large-scale issue for us in practice. Internationally, and this is one of our key points for you, abortion rates are lowest in health systems where contraceptive services are most readily available. I believe, and we hope in the ICGP, that we've come a good way in Ireland in relation to this, but there is more to go. There are definite barriers to contraceptive services in Ireland, chiefly relating to cost, and in instances involving adolescent women, their own concerns regarding confidentiality as well. The Eighth Amendment does not typically impact upon contraception and emergency contraception management for Irish women. It has made little or no difference to most GPs and most individuals in their consulting around unplanned crisis pregnancy. Management of crisis pregnancy. To help outline the typical crisis pregnancy scenario, we outline a typical example. And with no disrespect to Mary Murphy from Cork, we have Sandra, who is 38 years of age. She attends her GP. She has 3 children, but recently separated from her husband 3 weeks previously, as he had become increasingly abusive towards her and her children. Her GP has become more concerned about Sandra's isolation and lack of supports. Sandra says she missed her period 2 weeks ago. She thinks she may be pregnant, but she hasn't checked yet. She is concerned and anxious. She's arguably on the threshold of a crisis in the consultation. Why didn't she check the pregnancy test before she came? I think if she had 3 children hanging out of her and an unsupportive husband, these things happen. But people come to us in our practice in large numbers all of the time from different circumstances. Before her doctor performs a pregnancy test, she explores Sandra's feelings. She asks how would she feel if she was pregnant? Would she be happy if she found she was pregnant? At which Sandra bursts into tears. The GP listens to her many concerns, readily shared, and explains clearly that no matter what happens, the practice will be there to support Sandra today, tomorrow and next week and well beyond that. The GP proceeds to check a urine sample and it confirms that Sandra is in fact pregnant. She is despondent and devastated. She says she doesn't want to be pregnant. Every crisis pregnancy is different. The reasons why a pregnancy is unwanted is both personal and unique to each individual woman and her family, but the approach to managing crisis pregnancy as a doctor, as a primary care physician, as a general practitioner must be the same. We must confirm the pregnancy. As the vignette outlines, GPs do not assume that all pregnancies are always wanted. GPs are well placed to sensitively inquire about the woman's feelings and to confirm a pregnancy. And we hope that we do that in as many cases as we can, knowing that sometimes because of the feelings and the concerns, there's a miscommunication or there's difficulty in the communication. It's very difficult to be fully sensitive at all times, but we do our best and we do hope and we do feel and believe that most of the time the experience is positive and supportive despite the difficult circumstances. We proceed to non-directive counselling and discussion of options. Next steps in management are to support the woman reach the best decision for her. Main consultation objectives for the GP involve maintaining or establishing trust, helping the woman formulate a clear definition of what the problems are, and establishing the goals of management so that the crisis can be resolved for her. This involves non-directive, non-judgmental, compassionate, empathetic listening. One of my colleagues in our run-up to preparing for this observed that often the best thing we can do is to remain silent, that the opinion of the GP should be silent, that the focus should be on listening and on understanding. A doctor has an ethical obligation not to allow her own personal moral standards influence the treatment of patients. Where the doctor has a conscientious objection to a course of action, they must explain this to the patient and make the names of other doctors available to them. This has been stated through ICGP policy and training from the early 2000s and most recently in our updated guideline from 2014. Effective communication in crisis situations demands time, considerable patience and careful thought. The GP must enable the woman to reach an informed decision to alleviate emotional disturbance, whatever decision is made, and lessen the risk of further unwanted pregnancy. Pre-existing long-term relationships between GPs and the people who attend them is critical in enabling this. In practical terms, this may mean 2 or 3 consultations scheduled rapidly over 5 or 10 days. In the familiarity of general practice, we hope that women do find space, are listened to, and can share, explore, and address their concerns with their own doctor. Supporting this is a core value of the ICGP, so that these consultations, and indeed any other consultations involving the woman and the process of decision-making, are all undertaken in a non-directional and fully supportive process. Occasionally, specialist counselling is required. For example, if a woman is younger, has poorer support structures, or has a significant mental or psychiatric illness, they may benefit from specialist counselling. In this case, Irish GPs recommend specialist accredited counselling services which offer accurate information. These are funded by the HSE Crisis Pregnancy Programme, and by and large they enjoy the confidence of the ICGP and have been extremely helpful during these last difficult decades around this issue. Continuing the pregnancy. If a woman chooses to continue her pregnancy, her GP will continue to provide compassionate support, antenatal care, postpartum care to her and support for the child. Choosing abortion. In the clinical vignette above, our patient Sandra chooses to travel to the UK for an abortion. For women who choose an abortion, GPs cannot refer or make an appointment on behalf of the woman to a clinic in the UK, but would typically make a copy of the medical records available to be taken over as part of the care process. GPs would also encourage women to return to the practice after the abortion if they have any concerns. GPs would also discuss post-abortion contraception. Irish GPs may need to consider arranging an urgent dating ultrasound, for example, if the dates around the pregnancy are uncertain, which not infrequently happens, particularly if the social background is chaotic or stressed. Any GP who has a conscientious objection must refer the woman to another GP, either within or outside of their own practice. Medically, abortion is regarded as a relatively safe procedure for the woman, and it is carried out in large numbers in other jurisdictions. We note that some women, those for example who are disabled with a physical disability, without financial means, individuals who are on direct provision, asylum seekers, are particularly disadvantaged and unable to travel to access abortion services. The ICGP understands that an increasing proportion of women will purchase online hormonal abortifacient medication. In these instances, it may or may not become known to their GP in subsequent consultations, but we find over time that everything comes out in the wash. It may come out 1 or 2 years later, or possibly 5 or 7 years later. There is clearly increased use of illegal abortifacients, both from anecdotal evidence from GPs and objective measures such as custom seizures and the studies that we've previously heard from Janice. Issues pertaining to the Eighth Amendment and relevant legislation. We've slotted this in under a heading, Cumbersome Clinical Guidelines, and these have been referred to by my obstetrical colleagues and the difficulties that the current amendment throws up in this context. The Eighth Amendment and the Protection of Life During Pregnancy Act 2013 allows for lawful abortion where there is a real, proven and a substantial risk to the life of the mother. This is the legal concept. You've already been given data in relation to the huge infrequency with which this legislation is invoked, so I won't go over that again. It is in the paper that we're providing for you and will be accessible to you. In rare cases under Section 9 of the Act, process is characterised by substantial delays, typically 4 to 6 weeks at a critical period, in accessing termination of pregnancy. Further evaluation by a second psychiatrist, frequently outside the woman's community, really adds to incredible difficulties in this tiny number of cases. The Abortion Information Act indicates that GPs can and do discuss all options pertaining to crisis pregnancy. However, the 1995 Abortion Information Act does not permit GPs to either refer or to actively advocate abortion services. This restriction on practice can be challenging when caring for women with complex medical histories or with high medical risk, but we get on with it. Inaccurate information from counselling agencies. We would concur with the observations of Janice. We would like to point out that inaccurate information which is delivered by unaccredited counselling agencies is sometimes viewed by GPs as harmful and needs to be regulated. It particularly tends to incur delay, is the experience we have with it, at a time when delay adds to medical risk and adds to the stress and the tension perceived by the individual. Winding down, again, we would care to wish you the very best in the work that you're doing, and we greatly appreciate being consulted in relation to this because we regard this as an important part of the care we provide in your communities as general practitioners. Most GPs and many individuals who attend GPs in the course of an unplanned pregnancy do not experience the Eighth Amendment or the process required for the operation of the current legislative framework to be satisfactory, relevant or helpful. Crisis pregnancy continues to be a reality facing many women and their partners in Ireland on a daily basis. It is conspicuously evident in general practice, and a substantial proportion of these women choose to access means of termination of pregnancy. In the last 2 decades, there is a shift from surgical terminations to chemical or medical terminations. And in Ireland, if we look at other European states, we're probably about a decade or a decade and a half behind. But this is what's happening in our communities. From a practical perspective, and respecting cherished and sincere concerns regarding the right to life of the unborn child, the majority of GPs, and indeed Irish citizens, will understand and acknowledge that in many instances of unplanned and especially crisis pregnancy, a substantial proportion of women in Ireland will continue to choose and undertake termination in neighbouring jurisdictions or by means of medical abortifacients. From a purely whole of society perspective, building on good work already done by many agencies, including our own college, in removing all the remaining obstacles and barriers to contraception for all women, almost certainly holds greater potential in terms of reducing the numbers of crisis pregnancies and ultimately meaningfully reducing the number of terminations in a meaningful way. In preparing for this submission, we did review our procedure, the training that we've put in place for members of the Irish College of General Practitioners and GP trainees, and we did also consult among ourselves as much as time allowed between the request for our submission and preparing it. And we have made it our business to consult among ourselves. It is our collective experience now in general practice that in the majority of such instances of unplanned, undesired pregnancy, the woman opts to follow through with the pregnancy. This is felt to most likely occur among women from more deprived backgrounds or migrant backgrounds and living under direct provision, where cost of termination and ability to travel are real barriers for these women. There is a tacit assumption among many GPs that reduced levels of enfranchisement result in increased levels of acceptance of continuing with the pregnancy. Women disadvantaged in these circumstances undertake to maintain the pregnancy as they see it as the only viable option to them. It is evident to many GPs that the decision to continue with the pregnancy is frequently taken on the basis of financial considerations and non-standardised access to service. Poor women accept pregnancy because they can't get together €1,000 to fund a termination abroad. Women from less deprived backgrounds are more likely to undertake a termination because they and their partners can afford it. This reality in practice clearly adds to the sense of suffering for an important proportion of women, their partners, and in some instances their GPs. Inequality is writ large across most aspects of our health service, and this area of care is no exception. In keeping with current legislation, GPs do not provide formal referral letters to abortion clinics. Some GPs provide women concerned with a copy of their medical notes. In such instances where the choice is made for termination, GPs do remain engaged with their patients for the most part and have felt it necessary to continue to reassure any undue concerns regarding substantial or increased levels of mental health or gynecological complication arising among women following terminations. This is in keeping with international research. These women are still unnecessarily afraid about complications and side effects of termination. The prevalence of postpartum depression is a reality for those women who elect to continue with the unplanned pregnancy and requires to be considered. It is a real issue for GPs and their patients in this context, where unplanned pregnancy is a known risk factor for postpartum depression. Preoccupation around suicide, around diagnosis of unplanned pregnancy, is far less of a problem than postpartum depression in the wake of continuing with an undesired, unplanned pregnancy. Ladies and gentlemen, thank you very much for your attention and your consideration. Thank you kindly.
Well, I really want to thank all of the speakers in this two-part session this afternoon. There was an awful lot to take on board, wasn't there? We're now going to go into private session, and you'll have an opportunity to take it on board further by discussing the issues that we have heard about around the table. So our next public session will be at 4:30, and at that time our 4 speakers will answer questions posed by the members. Thank you very much.